So after the Indian Health Service had got accepted into this Robert Wood Johnson Health Services Research Scholars Program at UCLA and Rand, and through that got training in research, then got accepted into a position back at the University of Iowa, which I've been in basically for the last 30 years, which is joint between the College of Dentistry and the Public Policy Center. And I was silly enough coming out of grad school to think that I could start a health policy research program when the center was first getting going. And thankfully it was able, through collaborations and working with different people, to make that work. And then I've been director of the center for the last 12 years, and we've been taking on a greater role across campus. So it's just sort of, again, that whole idea of you never know where these things are going to be going when you get started with them. And so let life kind of take you and go with it. And where that has led me is now into, well, one other thing that happened along the way was my senior year in dental school, we had to do a 12-week extramural rotation, and I was allowed to go out to Washington, D.C. and work in Senator Harkin's office for 3 months. So I got to see really how the whole policy making experience worked, and I was doing research for their health legislative aide at the time, who didn't have enough staff. And that really led me to understand how important the kind of research that we all are doing to help inform policymakers, because they don't have that knowledge or understanding, and they don't have that expertise, and they don't have the staff. And so the kinds of things that we're talking about doing is really important. And so it really is, the whole time I've been doing this, my emphasis has been on health disparities and health insurance coverage. So I'm going to share my screen here. And just walk through a discussion of the Affordable Care Act as we've been talking about. Everyone see that okay? And where are we, where we've been coming from, and where are we now? Switch that. So really what we're talking about with health disparities is what I'm going to be talking about, the Affordable Care Act. What do we know about the health insurance expansion and the changes? So when we talk about health disparities, the official definition are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. That kind of, I think you can sort of grasp what that means from that definition, but how it actually plays out in health policy discussions is really important, and I think often missed. And so we often think about this in terms of race, ethnicity, could be gender, education, income, disability, sexual orientation, geographic, urban, rural kinds of things. But there's a lot of things that we mix up access to care and healthcare utilization in the terms that we use. And so what I'd like to do is kind of talk about some of those distinctions in addition to talking about the Affordable Care Act. And the health disparities really can happen from lots of things, not just a person not having health insurance. And so if you listen to the political debates right now, you'll hear people talking about whether people have a right to health care. And when they're saying that, they're only saying that in terms of insurance. So like folks that have been promoting Medicare for all, been saying, well, we need a right to health care in the United States. Well, Medicare for all is not going to give a right to health care, and it's not going to give a right to health. And the whole reason that we're doing all of this is about trying to improve health, which we'll talk about that. So health disparities really happen for a whole variety of things well beyond having health insurance. Poverty, environmental threats, inadequate access to healthcare is one of them, financial access being one of those reasons that you can't access care. Individual behavioral factors, education inequalities, racial bias. There's a lot of reasons that we have health disparities, and this has really been brought out with COVID, when we've been seeing different racial differences, saying that African Americans are 2.5 times as likely to die from coronavirus disease. Well, that's not necessarily because they're going to be more likely to be affected, but they're going to have underlying health conditions and access to health care and a lot of other issues that really play together. I think it's really important to think about this holistically when we're talking about this. And was there a disparity in health insurance coverage? Absolutely. Before the Affordable Care Act, Hispanic Latinos, this is the uninsured rate. You know, a third of the Hispanic Latino population in the United States was basically uninsured. 1 out of 5 non-Hispanic Black African Americans were uninsured. You know, disparities obviously versus white and even Asian populations. So is there a reason that we needed to be looking at this? Absolutely, from a health disparities perspective. But also those underlying health conditions before. So this is obesity by race and age before the Affordable Care Act. And it's kind of complicated with lots of different bars, but the non-Hispanic white is the dark blue bar, non-Hispanic Black the second, the third is non-Hispanic Asian, and Hispanic Latino the fourth. And as you can see, the Black and Hispanic Latino populations have a much higher proportion in both men and women of underlying obesity, leading to diabetes and a lot of other secondary health conditions. So those are things we always have to take into account when we're talking about just straight what you might think of as health policy, health insurance, all of those kinds of things. This is from a study that we did, and we were doing this every 5 years, and then the Department of Public Health lost their funding. So the most recent data that we have is from 2010, but this is looking at self-reported children's oral health. And so apologize that the legends I see you can't see there, but the African American is first, and white, Hispanic, or Asian and white are the next two. And this is the self-reported rating. And so there's lots of ways that you can get at health status. Self-report is one important one. There's a lot of other ways of doing it, and you can argue about the advantages, disadvantages. But basically, there was a distinction. Oral health and mental health are two of the most underserved areas when we're talking about health disparities. One of the things that you often hear about the US healthcare system is that we spend more money than everybody else and we have worse health outcomes. How many of you have heard that before, right? And in a very simplistic sense, that is true. So that we spend way more, whether it's as a proportion of GDP, to our entire economy, or on a per person spending basis, we spend way more than everyone else. And if you do look at things like female life expectancy, male life expectancy, infant mortality, we're at the bottom. But what do you think, if you think about what goes into how long we live or infant mortality, what are some other things that might be important to be thinking about whether this, because this sort of assumes that it's directly related to our healthcare delivery system, right? That we spend more on healthcare utilization, healthcare spending, and we get worse outcomes. But what else factors into that? What are some things that you can think of? You can just.
I mean, there's social factors. I mean, education, access to, like food deserts, good food, right. The type of parents you have, the environment. I mean, the environment that you live in. Yeah.
Right. All of those things are really important and do not get captured in this. Right. It's a little overly simplistic, and I have a whole lecture on this topic we're not going to get into today, but let's just leave it at it is very overly simplistic. Can we do better? Absolutely, but there's a lot more involved in this. So that gets into this whole issue of health versus healthcare, and that many determinants of our health are really best addressed by things outside of the direct delivery of healthcare services. And we're seeing this right now with COVID. What we're really seeing, we talk about it in terms of as if it's a medical care issue, but it's really a public health issue. It's how do we treat populations, not how do we treat individuals. By the time we're treating an individual on a respirator, the whole thing has failed. And the whole thing has really, we've not done what we were supposed to do to best address an epidemic like COVID. So the fact that we don't have a comprehensive public health system in the United States like many other countries, and that's unfortunately a bipartisan issue. Both parties underfund public health until there's a crisis. This is a little unusual right now when you see as partisan as this has become. Once you have the crisis, usually some of that goes away and then it's, oh geez, we need to fund public health. Now we're seeing really partisan distinctions. That the closest thing that I can recall to that was back when HIV/AIDS really first started around 83, 84. And there was starting to be some political backlash, particularly since it was primarily a disease that was seen as a part of the LGBTQ community, and particularly among gay males. And that was during the Reagan administration. But interestingly, at that time, you had a Surgeon General by the name of C. Everett Koop, who, when he was first brought into office there, public health people hated him. They called him Dr. Kook. They thought he was going to be awful, and he turned out to be the best thing they could have had, because he was coming a little bit from more conservative perspective, if you will, and then had the street cred to move the Reagan administration in a direction that we don't have that right now with the Trump administration. So you're seeing these sort of weird politics with that, unfortunately. So we think about in a different way, what are the determinants of our health and what affects our health? About half of it are lifestyle factors, like Samir was mentioning, a number of those, whether it's nutrition, physical activity, wearing a seatbelt, wearing a motorcycle helmet, all those kinds of things. About 20% are environmental factors, people that are living near toxic waste dumps are sort of the far extreme, but there's a lot of other things. In Iowa, we have a lot of radon, for example, and people, if they don't get the radon tested, we have a higher rate of lung cancer among non-smokers as a result of radon. Your genetics. We all know of people that have smoked their entire life, lived to be 95, and other people have died at 22. And so, there's definitely a genetic component, but really only about 10% of our health status is really directly related to the healthcare delivery system. But where do we put our money? So not exactly if you were going to script this or you were going to think about this in a systemic way, right? We would flip that completely. And those lifestyle factors are things that are really only can be affected from a public health system, not only, but primarily. Individual healthcare and working with a physician and things like that, they're not really going to get you there in the same way. So this is what some people call the social determinants of health. I really just call it the determinants of health. And so if you want to just take a look at that list for just a second. So these are all the things that you can imagine are going to be really important to a person's health status. Which one of these do you think is most important? Any thoughts?
Early childhood development or food security, probably.
Yep, I mean, you pick. All of them are important, right? We know early, that 0 to 5 time is incredibly important for the whole rest of your life, right? To me, housing is probably the most important. And there are housing advocates and housing experts that they have a mantra, they say housing first. And to me, that makes a lot of sense, because if you don't have stable housing, you're not going to have good early childhood development. You're not going to probably be stable in terms of what school you're going to. Can be more likely to have difficult employment, food security to be a challenge, et cetera. But we don't think of housing in the United States as a health issue at all. And that's something that I think if there would be some way to change that, that would be really important. But as I drop the social from the determinants of health, because that makes it sort of soft, sound soft and maybe not that important. Well, no, this is what's really important. And so this is just sort of talking about how we've transitioned from actually 100 years ago, we got our biggest gain in health status through public health when we went through clean water, clean sewers, things like that. That was our biggest gain in health status ever. When you start moving into the individual healthcare eras, we gain, but only on the margins. If you think about in developing countries, that's why those types of things are so important. If you've got open sewage running down the middle of the streets, whatever kind of an individual healthcare system you have really doesn't matter. And you can see that in resulting changing mortality patterns. And the reason I've got these sort of older data is because it's the only thing I've been able to find in terms of cause. But basically what this is showing is that 100 years ago, we had an infectious disease situation where, because of poor public health and bad sewers, bad sanitation, et cetera, these were infectious diseases. As we've gotten those things under control, we've moved much more towards chronic disease states, with the causes being things, if you look at the column that says 2000 with the asterisk, this is what's causing the problems in 2007. So it's not the heart disease, it's the tobacco that's causing the heart disease, or poor diet, physical activity that's leading to heart disease. Some of these things are also diseases of older people. As we're living longer, you're much more likely to have heart disease, much more likely to have cancer, much more likely to have COPD. So there's some almost good thing about some of these changes. But if you look at, again, a lot of these are behavioral. Alcohol, toxic agents gets into that. Environmental, but motor vehicle crashes, firearm use, those are things that touch on that behavioral. So all of that before we even talk about the ACA, because I think it's really important to put that in the context of when we start talking about insurance. And with the Affordable Care Act, there's really two components that I think are really distinct, but we mush them together. And mostly when you talk about the Affordable Care Act and what you hear, it's all about the insurance expansion. It's all about, do people have more insurance? Medicare for all, it's about giving people more insurance. But there's really a second part of the ACA that was just a really small part that was supposed to be a Medicare experiment, and that was the development of these accountable care organizations. That has had a much bigger change on our healthcare and our healthcare delivery system than anything, and we don't talk about that much at all. And it's really unfortunate. I'm not going to talk about it as much either today because it also gets really complicated. But if any of you here have heard about Unity Point, that's a huge healthcare system, and there's a huge consolidation that's gone on all around the state as a result of the allowing these accountable care organizations, changes in payment model, and things that are really affecting the delivery of care. The big difference between these two also is we know how to do the insurance expansion. If we wanted to, we could do that tomorrow. We could do a Medicare for all. We could close the gaps on the people who are uninsured. We know how to do it. The delivery system changes, we really don't know how to do it. We don't know how to provide good quality, reasonable cost care to these people now who have a lot of chronic health conditions which are going to go on for a long time, or our combined physical health, mental health problems with people. And many of our highest cost utilizers are people with mental health comorbid conditions are called mental health and physical health. Very difficult to control because the behavioral aspects, all these things we're talking about, are much more difficult. So when the Affordable Care Act was passed, as you all know, people didn't understand it. And reform is scary in all kinds. And this is President Obama saying, maybe I should have been more specific. Well, he was also being criticized for being too specific, that it was a 2,800-page bill, that it was, nobody could understand it because there was too much there. And it's not just the Affordable Care Act. If you talk about a major transportation bill or anything like that, it's very difficult to get your arms around it. But healthcare is so personal that it also evokes a response from people that's striking. But then President Trump came in and he said it's an unbelievably complex subject. Nobody knew that healthcare could be so complicated. Well, some of us kind of knew that, but it's also one of the reasons that the Trump administration has not been able to create any kind of serious change. They have nibbled away at some aspects of it, but it is so complex and so personal that the serious changes that they had been talking about coming into office really haven't happened. I'm going to see if this will let me play this video. And I think I'm going to have to move my screen over here.
These government shutdowns have happened before. The last one was in 1996. But the debate on this one is particularly heated because people have such strong opinions about Obamacare. Interestingly, the polls show that most Americans say they don't like Obamacare, but they love what's in it when it all gets broken down. It's like the opposite of a McNugget. So, it's interesting. And when there are complicated issues to study, most people just side with whoever they usually side with. So I decided to conduct an experiment today. We sent a camera crew out on the Hollywood Boulevard to ask people which they thought was better, the Affordable Care Act or Obamacare. Now, as you may know, Obamacare is just a nickname for the Affordable Care Act. They're the same thing. But lo and behold, we found people who did not know that, and that didn't stop them from weighing in on it.
We're talking about healthcare today, and which plan do you support, Obamacare or the Affordable Care Act?
The Affordable Care Act.
And what is it about Obamacare that you do not like?
I just think that there's a lot of holes in it, and it needs to be revamped. I think
And you think the
hasn't been thought out.
You think the Affordable Care Act is a better plan than Obamacare?
Better, but I'm not happy with that either.
What do you agree with, Obamacare or the Affordable Care Act?
I'm more sort of towards the Affordable Care Act. But I'm also very sympathetic for people that don't have the ability to have proper medical insurance.
So the Affordable Health Care Act is still a better option than
Yes.
Obamacare?
Yes.
And why do you not agree with the Affordable Care Act?
Well, I think it's not really available for all.
So the Affordable Care Act is more affordable than Obamacare?
Just the name says it all.
Right. Do you agree with the Affordable Care Act?
Absolutely. I think it's nice that everyone can afford it, and everyone should be able to afford it, but to force people to pay something and then doctors to make something, limiting their ability to do their job, that's kind of anti-American.
Right. So Obamacare is un-American?
I think it's kind of un-American to force people. What if they can't afford it? What if they want more coverage?
And the Affordable Care Act is American?
I think it's more American because it allows people to make their own choices on what they want and who they want to work with.
Do you agree with the Affordable Care Act or Obamacare?
The affordable.
And why do you prefer the Affordable Care Act over Obamacare?
I just don't agree with the whole Obamacare policy thing that's going on. I just don't agree with it.
And do you believe that an informed citizenry is essential to a democracy?
Yes.
So you disagree with Obamacare?
Yes, I do.
Do you think insurance companies should be able to exclude people with pre-existing conditions?
No.
Do you agree that young people should be able to stay on their parents' plans until they are 26?
They should be able to, yes.
Do you agree that companies with 50 or more employees should provide health care?
I do.
And so by that logic, you would be for the Affordable Care Act?
Yes.
What plan do you support, Obamacare or the Affordable Care Act?
The Affordable Care Act.
And why do you support that over Obamacare?
Do not like Obamacare. I don't like anything that has to be forced for everybody to buy. This is not good.
Do you think Obamacare is socialist?
Yes, I do.
Do you think the Affordable Care Act is socialist?
No.
Do you believe that Obamacare will eventually lead to gun prohibition?
Yes.
Do you know that Obamacare and the Affordable Care Act are the same thing?
No, they're not. Thanks, you made me look stupid.
That's what we do.
Okay, you did good.
Oh, hey, look, this the audience. Welcome, stupid people. You have a home here with me.
So why is that so important? Well, we're trying to do research. We're trying to give people information, and it's really difficult when people don't have the same level of knowledge or understanding. And it literally took 7 or 8 years for people to understand what the Affordable Care Act was and what it might mean for them. And it makes it very, very tough. And when we think about different ways that we can reform a healthcare system like the United States, the whole spectrum, in a what you could say would be more left, but more of a government role, would be something like the National Health Service, like they have in Great Britain, where all of the facilities are basically owned by the government. All of the providers are government employees, plus the insurance. In Canada, you have mostly private providers and private facilities, but you have a government-run health insurance plan. What people thought was going to pass with the Clinton healthcare reform was an employer mandate. What we're really talking about with Affordable Care Act is a slightly right of center approach, in the idea that it was revolving around an individual mandate and individual's responsibility to have insurance with some government involvement. And then, you know, from there, less role for the government in terms of what we're doing. So in terms of the insurance expansion part, what we've done in the United States is very different than virtually every other country, is that we've continued along an incremental approach. Prior to World War II, there was literally almost no health insurance coverage at all. And then there was, during the war, a shortage of adult male employees in particular. And so employers started offering health insurance as a benefit to try to attract and retain employees. We then started offering, the government started offering the ability for businesses to write off the cost of their health insurance on their taxes to be able to encourage it. But it's not like we have this employer-based system because we're a free enterprise government system and all those things. It just sort of happened. Then in 1965, you had the passage of Medicare and Medicaid, and that was picking up then the biggest groups that were missing insurance coverage. And those were seniors, because once they retired, they had nothing. And at that time, they were also the poorest age group. They're now one of the wealthiest, in part because of Medicare and because of Social Security. There's a safety net for older folks that we don't provide for children or young families. And it's sort of an interesting kind of a disconnect. And then Medicaid, we think of as primarily a poor moms and kids program, but most of the money goes to people with disabilities and people in nursing homes. About 2/3 of the money actually goes to those two groups. Very important, but not what Medicaid was originally intended. And when you hear people talking about Medicaid, not the way that they think of it. Then we added the Children's Health Insurance Program in 1997 for children of the working poor. And then the Affordable Care Act, which was really, if you think of who was left, a lot of it were either single adults who were low income but didn't qualify for Medicaid because you had to be a poor mom or a poor kid, or people who were in the individual and health insurance market that would literally go out and buy a policy from an insurance broker. And if you had a pre-existing condition, you couldn't buy it. Or if you got sick in the middle of the year, you might get dropped, or your costs might go up the next year to the point where you couldn't afford it. So those were the changes in the populations that the ACA was really designed to help. There were a whole variety of things that went in prior to the individual mandate in 2014. But most of what we think of as the Affordable Care Act started in 2014 with the individual mandate. The health insurance marketplaces started where people could buy subsidized private insurance. So this really was a public-private partnership. Again, thinking about that slightly right of center approach of the ACA, and then the Medicaid expansion. So what we've continued to do is taken the people who are the highest cost, highest risk, and pulled them into government programs between Medicare and Medicaid, and we've left the lower cost, healthier, lower risk people with either the employers or with the individual insurance market for the most part. And so the health insurance marketplaces are those online where you go to healthcare.gov and you can buy subsidized private insurance that way. And if you should go and just try it sometime and just sort of look at it. You don't have to put your information if you just want to see what's available. There is an open enrollment period at the end of the year, where it's the only time you can do it unless you have a major life change. But one of the big changes is that for the first time, they were saying that the essential health benefits, that they standardized what had to be covered. This still doesn't apply to everyone, but before, and if you have employer-based insurance, what you get from your employer is still intended just to recruit and retain you. It's not there because that's what you need to be healthy. So Medicaid program for kids, they went through, and everything that is covered is what is determined that children need to stay healthy. This is the whole list that for what are called Affordable Care Act compliant insurance plans, they have to cover all of these things. Over the years, we've seen a lot of problems with mental health, what's called mental health parity, meaning mental health is treated the same as physical health and that your insurance should be the same. With the Affordable Care Act, they did that. They didn't do it with dental services in the same way, that mental dental thing that I was talking about. So we still have oral health disparities, which we know affect physical health, can affect particularly people like with diabetes and other things like that, and different types of heart disease, but that isn't covered in the ACA in the same way. So when you go online, you can then see different prices depending on what proportion of your care is likely going to get picked up. And so they call these metal levels of bronze, silver, gold, platinum. Most people's employer-based plan is about like a silver plan, about 70%, and then there's usually a cap, so you don't have to pay more than $5,000 a year or something like that. But the cost for people with insurance through their employers has been ratcheting up, and the costs that are getting shifted to the employees are getting higher and higher all the time, decreasing the quality of their insurance. In terms of the Medicaid expansion, this is the current map as of August of 2020. And so you do see sort of a political left-right or red-blue pattern to this. And most of the uninsured that we have today are really in Texas and Florida, if you look at the largest, because they have opted not to do the Medicaid expansion, even though the federal government is paying for 93% of the cost of Medicaid. Regular Medicaid is a federal state match, roughly 2/3 state, I mean, 2/3 federal, 1/3 state. With the Medicaid expansion population, it's actually 93%, and yet Texas and Florida and some of these other states are not going along with it. And because of that, millions of their citizens are uninsured because of the political Obamacare thing that still is there. And so it's really unfortunate for the people in those states because they don't have another option. But what we have been seeing is some other Republican-leaning states have jumped in. Samir, were you going to say something?
Yeah, no, I had a quick question. So then who would mandate, or who would accept that, or would implement that in their state? Would it be the governor thing? Would it be the state Congress or state Senate?
It's usually either the governor's office or the state legislature, depending on what the jurisdictional kinds of things are. And then you have a number of states right now that what they've done is they've done a referendum. So for example, Maine was one of the first. They had a Republican governor who wouldn't do it. They got it on a referendum, and then it passed with a 2/3 majority to be able to have it. Now, Nebraska did too, and yet they still haven't implemented it. I believe Kansas has also, and so it varies a lot, but the end result is that the citizens of the state, if you're at, for example, the crazy thing, and this goes back to the Supreme Court issue. So I told you for Chris's sake, I'd mention a couple of Supreme Court cases. So way back in 2013, there was a Supreme Court challenge that said that the individual mandate was unconstitutional, that the government couldn't make you buy health insurance. And Justice Scalia at the time had the famous quote about, well, we don't make people eat broccoli, why should we make them buy insurance? Justice Roberts, Chief Justice, actually passed the deciding vote, and they ruled that it was based on that it's a tax. And that's what the current challenge, which is going to be reviewed this fall, is about the fact that in the 2017 tax law that was passed, they said we're no longer going to enforce the individual mandate and the penalty if you don't have insurance. Because before, if you didn't have it, there was a penalty that the IRS would enforce. And they're saying, so don't enforce it, so they're saying it doesn't exist. So that means, you know, the whole thing is then unconstitutional. But what also happened in that 2013 ruling is that they picked up, there were 4 different components. The main one was the constitutionality of the individual mandate. The second was whether they could force states to do the Medicaid expansion. At the time, everyone thought if there's going to be something that's going to be unconstitutional, it would be the individual mandate. The Medicaid expansion, the feds were paying 100% for the first 3 years. How could a state refuse it? And yet the Supreme Court ruled that the states could opt out. So there was a weird part of the ACA that said before, under 100% of poverty, you were not eligible to go into the healthcare.gov site and get subsidized insurance because they figured they would all be in Medicaid. And again, that was pulling off the higher risk people into the government program, leaving the lower risk people for the private insurance. Well, because that was ruled unconstitutional, if you're in Texas or you're in Florida and you're at 99.9% of the poverty level, you don't have no option. If you're at 100%, you actually can get subsidized private insurance for virtually free. And I wrote an article in The Hill, which is a publication, part political, part policy, slightly conservative, but basically saying one option they could do would be to change that and drop it down to 0 for people to opt into the private insurance. That would then sort of get the conservative states away from being concerned about this government takeover and saying it's a public-private partnership, and then allow these people to get the subsidized insurance that they really need to get. But nobody wants to go near the ACA. The politics are such that it's been very challenging. We'll see what happens post-November. So what do we know? Because of that, we still have about 30 million people who are uninsured, but that's down from 50 million before the Affordable Care Act. So we picked up about 20 million people with insurance, and there's still about 25 million underinsured. Those have been going up a little bit in the last couple of years under some changes in the Trump administration. Not a big change, though, the employer-based insurance side. Even though they put in a mandate that all employers over 50 employees have to provide insurance, almost all of them were before. And so because of that recruitment retention issue. So that didn't really change that much. In terms of the disparities, so these are just overall for adults who are uninsured, by type of insurance, including uninsured. So you can see that top line was the proportion of people with private insurance, and that stayed relatively the same. Among all adults, the uninsured rate dropped from about almost 20% to 12%, and the proportion of public insurance went up. Similarly for children, even though the rate for children was lower overall, for both near poor, poor, you saw a significant decline. Again, this is getting at the health disparities on a poverty level status. Even a slight decline for the not poor. This is for adults similarly by poverty, and saw a significant decrease of uninsured or increase in insurance for the near poor and the poor. By race, ethnicity, again, Hispanic Latino population, African American population declined significantly in terms of the proportion who were uninsured. So the ACA was able to reach a number of the people from a health insurance disparity perspective. This is something that's a little bit in the weeds, but I think is really important. And this has to do with uncompensated care. So uncompensated care is care that healthcare providers have to cover the cost for because somebody can't afford it. And so it shows the impact early on. I haven't seen one more recently about uncompensated care costs by whether a state did the Medicaid expansion or not. And this gets at the value of everyone being covered, or the value of a state like Texas or Florida if they did the expansion on the other already insured citizens of the state. So once you cover someone with Medicaid, the uncompensated care costs go down, which are the costs that get spread across to all of us. So that orange line is in the Medicaid non-expansion states. It basically didn't change. So it wasn't something that was going on systematically, but in the Medicaid expansion states declined significantly. And so there is value to others, even in just dollar amounts, if you reduce the number of people who are uninsured. So what's been happening since the ACA and what's been going on? Well, we know there was initially an attempt to repeal and replace, it was called. Legislative activities have been going on, some legal challenges, and some things in the states. So at first, the Republicans in the Congress between 2016 and 2018 controlled both the House and the Senate. 2018, the House flipped to the Democrats. And they thought during that first two window when they controlled the House, the Senate, and the President, that they were going to be able to repeal the ACA and replace it. They campaigned on this for 7 years. But by this time, as I mentioned earlier, all of a sudden people actually were starting to figure out what was happening with the Affordable Care Act and what the benefit was to them. And so it made it a little bit more difficult. This is our own Senator Grassley, who at the time of that vote, I just think for those of us who are interested in policy and research and giving people knowledge, this is another reason it becomes very difficult. When he said, you know, I could maybe give you 10 reasons why this bill should be considered, but Republicans campaigned on this so often that you have a responsibility to carry out what you said in the campaign. That's pretty much as much of a reason as the substance of the bill. Makes it really hard to say, you know, the values of this and that when that's what you're going to be voting on. And again, this isn't just him, but I think this just sort of speaks to some of the challenges. And basically what this is showing is that the attitudes right around that time toward the ACA were turning much more positive among people. And so that was another reason that the repeal and replace didn't work and why the House flipped in 2018, because the attitudes on healthcare really had changed. This is showing that the amount of people who are underinsured is going up, and that means there's certain types of insurance that the quality is not as good as it was before, and so it's not picking up all of their healthcare costs. And when you hear about that Obamacare is broken, there are components. Again, the Affordable Care Act did not fix everything. Did it move some things in the next direction, in the next stage? Yeah. But did it fix everything? No, absolutely not. And especially on that individual or non-group insurance market, it still is broken. It was broken, let's say, against the consumer to begin with. To some extent, it's broken against the insurance companies now because we haven't gotten everyone in the way that the individual mandate was expected to. So the whole idea of the individual mandate, it wasn't government big brother saying everyone should have insurance. It actually came from the private insurance companies saying, if you want us to get into the health insurance marketplace and you want us to go along with an individual mandate, then you're going to have to get everybody in. Otherwise, it's just going to be the sick people that are going to buy insurance and the risk pool is going to be bad. So that's why the individual mandate is there. When you get rid of the individual mandate and you start carving into some of the different types of insurance, then all of a sudden the risk pool for the private insurance companies doesn't work very well. So one of the things they did, they ended these risk adjustment payments, which were to try to help the insurance companies if they had a whole bunch of bad risk people, so they were less likely to do it. This has been evident in the number of plans, for example, in Iowa, who even are participating in the marketplace because the risk isn't good. In that federal tax bill, as I mentioned, that got rid of the penalties for the individual insurance. And not only does that make the pool worse, it reduces the Medicare and Social Security trust fund solvency because of different ways that payroll taxes then play out. And so this has a ripple effect. There's also been a push and an introduction of more emphasis on what are called association health plans. And these are plans that different groups of people put together. They don't have to meet the quality of the Affordable Care Act. They can be less expensive. There's a lot of room for fraud and other things. This is one of the reasons that they were basically made illegal in the 80s and now made more available. There's some under religious groups that are allowed now. Some of them might be fine. For some people, it might allow them to purchase something at a particular level that they weren't before. But overall, this carving out of the remaining risk pool for that individual health insurance market makes it really tough for that to be a really viable market. Same with these short-term health plans. This is something used to be, you may have heard of something called COBRA. If somebody loses their job, they can buy in, it's really expensive. Well, then there were these transitional plans to help. They were supposed to be 3 months, then they were made a year, now they're up to 3 years, again, non-compliant, and continue to carve at that individual market. As I mentioned, you do see a number of Republican and red states, though, that have been sort of figuring out the Medicaid expansion is worthwhile for us. They're often doing it with sort of what I'll call a slight conservative twist to kind of justify it. They won't cover everybody or certain things like that, that they can, but there has been a movement in that direction. And then there have been some administrative regulatory changes under the Trump administration that have, again, sort of hurt the ability of more people to get it. For example, there used to be an open enrollment period that was much longer. They cut that in half. They cut the budget for advertising about the open enrollment period by 90%. And then, as I mentioned, those cost sharing reduction payments, all things that are kind of undermining some aspects of the Affordable Care Act. And so that does have a ripple effect in terms of on health disparities. So in the first year, and the health insurance data, unfortunately, is sort of lags. But there's a feeling that by now, around 2 million people have lost coverage as a result of some of those changes. It could even be higher. One of the things we're doing right now is we're going to be doing a study in Iowa and looking at what are also the COVID effects. So we're doing a survey of consumers and trying to find out how many people, because they've lost their employment, have also lost their health insurance. And then the Supreme Court challenge, as I mentioned. So 17 states had sued the federal government in something, a case called Texas versus Azar, started in district court in Texas. That's now, originally the Trump administration was on against this case, and then they flipped and they decided to side with the people who were suing the government in support of getting rid of the Affordable Care Act. If this were really to happen, depending on the ruling, the different aspects of the Affordable Care Act are literally a fabric within the entire healthcare delivery system, and there's almost no way to untease it. And so it'll be fascinating to see if they were to rule that because of the lack of enforcement of the tax penalty for the individual mandate, what that actually would mean. Some of the COVID changes, because of the significant loss of employer-sponsored insurance. Right now, about 31 million people are unemployed across the United States. It's been estimated that about 27 million of them have lost their employer-sponsored insurance, and that might have resulted in about 5 million more uninsured. But again, these data are not, these are all estimates. They're not very good yet. But some of the things that have also come out of the COVID time, what services are essential? And so when you think about initially during March and April, all non-emergency services were shut down. And for some people it had some impact, for a whole bunch of people it really didn't matter. So what happened to all those services that needed to be provided? What really is essential? And now, when is it safe to get care? When is it safe to go back in? People are hesitant to go in unless it's something that's super essential. And then of course, what people are essential. And this gets to me back at the determinants of health. So am I that essential? Not as much as the person who's delivering Amazon, and the person working at the grocery store, and the person who's working at the gas station, who've had to work through all of this with minimum wage, maybe no benefits. Well, what are we going to do about those people now that we know that they're essential? Well, we're seeing right now in the debate in Congress about whether are they worth $600 to the people that were laid off a week or only $200. Well, what the thing they're not talking about is that they're saying, well, $600 is more than what some of those people would have made otherwise. Well, why were they making less than $600 a week? And are they truly essential? And then that gets at, again, the determinants of health. And if we're not going to provide a living wage for people, how can we expect people to be healthy? What does it mean for a public health system coming out of this? Who's going to pay for just the testing, treatment, all those things? And the value-based purchasing I won't get into, but it gets into a lot of things related to accountable care organization development that gets sort of thrown out the window. In terms of campaign issues coming up, on the Republican side, the Trump campaign is likely going to continue to say that the Affordable Care Act isn't working and that it's a government stretch, and continue to try to cut back support. On the Democratic side, since Vice President Biden is the person that made it through, you're going to see a more moderate approach rather than a Medicare for all. They're talking about a Medicare opt-in, so it would go down to 60. Some have talked about going to 55, that people could opt into Medicare. Again, that's probably the highest risk group and highest cost group of people who are left. Again, we're moving them into a government program. So we wonder why government programs are expensive. It's because we're picking up the highest cost, highest risk people. Public option was something to discuss the first time, was kicked out, and that would mean anybody could opt in to some sort of a Medicare-like plan if they wanted to. Pre-existing conditions is something that they're going to be talking about. You'll hear the Republicans talking about it, but in none of their plans are they protected, because that gets in that individual insurance market, and then it'll be interesting to see where the Medicaid expansion. And the interesting thing are the people over 400% of poverty, because that's where the subsidy in the health insurance marketplace ends. And a lot of things that you're hearing are actually about those people, because they have more political influence because they have some money, but have been left out of all this. Even though at the time, the opponents of the Affordable Care Act said it was too, you shouldn't have gone that high. Now there's talk, again, extend that up even higher. So overall, you know, the repeal and replace is dead once the Democrats came into the House, but the undermining of the Affordable Care Act still went on. And there's still going to be some of these indirect attempts to sort of do something, but we'll see what happens with the election and see where things sort of go generally over that. This is our puppy Vinny. And with that, I'm happy to stay as long as anyone wants questions. It is 2 o'clock, and if you need to opt out to something else, I certainly understand. Any questions from anyone?
I have a quick question.
Yes.
So you mentioned earlier that like generally the enrollment period for the marketplace is like at the end of the year, unless you have like a major life change.
Right.
So is like losing your job due to COVID considered like a major life change?
It is, but there's a certain day limit. I think it's 60 days on which you have to do it or else you can't opt in. And because there was no marketing of this, there was talk of doing it and making it much more available and open to people, but the Trump administration opted against that. So there are a lot of people who didn't know that was an option. And so once that time period ran out, they're sort of without that.
Thank you.
Yep.
This is more of a kind of related to Iowa question, and you guys as the teachers or faculty within it. I don't know if either of you have teaching appointments this coming fall, but if you do, there was an email today that briefed us about how there must be compliance for it, but there was really no kind of addressing of consequences of lack of adherence to it, which I would, as you know, how would you guys navigate those waters?
A great question. The way I've heard it described, there is supposed to be almost like a checklist of ways to approach it. You know, number one, so you're talking about the COVID situation and teaching it in person, correct?
Yeah. So I suppose like my question would be like, I'm going to class with some 50 other students, and one of my classmates is very zealous about not wanting to wear a mask or whatever it be. Right.
It's going to be a nightmare, I got to tell you. And this is one of the things I've got a real concern about. Number one, the teacher is supposed to have face masks there to offer. If the person refuses, there's a code of conduct issue that's similar to cheating that then goes into place that will go on the person's record. But what you do sort of in that situation, obviously you ask the person to leave. If they won't leave, they're supposed to then shut down the class for that day, report the student, or literally call campus police. none of which are great options. I think the more subtle ones are even some of the most difficult ones. So say you're in an hour-and-a-half lecture or a class, and you got somebody just sitting in the back and they're starting to get stuffy and they pull their mask down so it's not over their nose. Well, that's not using your mask appropriately, right? So how much, where do you intervene and in what way? And it's going to vary by class to class. But the main thing is that it's supposed to be a code of conduct issue. Everyone's supposed to be signing a code of conduct. And if they opt not to do that, eventually there will be expulsions and things like that. The first couple of weeks, though, will be very difficult.
And we have to sign on to the code, and then everyone is expected to sign on to the code of conduct.
That's my understanding. I don't know how they're doing that. They just announced today, I think the email you were talking about the distribution of the PPE.
Mm-hmm.
I was a little surprised that wasn't in there, but maybe they want to take more of here's the positive approach, here's we're giving everybody, and later they'll come in, here's the punitive.
Yeah.
But you unfortunately, you got to have some of both.
Yeah, no, I mean, I the only way that I saw that it being any way kind of working would be with some sort of educational penalty or institution penalty, and like money wouldn't work, this, whatever thing wouldn't work, so.
Right. I don't know. Chris, you have any thoughts?
So, I mean, I'm not teaching in a classroom in the fall, but when I'm thinking about this, I'm thinking about when I've taught in large lecture hall classes, and obviously it wasn't the same in terms of wearing a mask, but you do always have that potential that someone is going to draw attention to themselves, is going to create a disruption. And if I had to speculate, I think there's probably going to be like a lot of that in the first couple of weeks. And it's up to the instructor that they need to have a plan for that. And, it's not setting an example, but just showing that this is something that we're going to take seriously and that there's zero tolerance. And hopefully it doesn't come to the point that you have to call campus security, but I think there needs to be the willingness to do that if that's necessary to keep people safe. Pete, you'd reference sort of the difficult situation if someone pulls it down over their nose. I know that I would always say that, if you have to use your cell phone, don't use it in the classroom, but if you need to step outside and do that, similar if someone has a situation where it's really stuffy, take it outside. Don't do it in the room where it puts everyone else at risk. That's how I would approach it, just sort of drawing off of sort of analogs from when I was teaching some of these large classroom in these settings. Although, fortunately, it sounds like you're not going to have hundreds of people in the same room. But I think some of those strategies would probably generalize to the social distance classrooms that we're moving into. But yeah, I think it's going to be really important these first couple of weeks. They're going to be difficult, but the instructor really has to be willing to set that example early on. And I think to things like, cell phones, that was always really important. I think some of those lessons hopefully will help instructors going forward.
Yeah, that's a good point, Chris. Good analogy. Any other questions about the ACA or where it's going or implications or anything that you've heard you're kind of wondering about? So, Liam, are you talking?
Looks like you might be typing something. I wanted to comment. So Pete, you mentioned the Supreme Court case that's coming up. It's always dubious to try to make a prediction about what's going to happen. Do you think there's any chance though that they would strike it down? I'm pretty skeptical. I mean, I don't tend to think that John Roberts has become a liberal, but I think that he definitely showed skepticism years ago about striking the whole thing down. And I would, I think that given his sort of newfound institutional position, I think that there's little chance that he would entertain the arguments that have been made by some of these Fifth Circuit cases. Do you share my skepticism?
I do. As you know, many of these cases, what they do is they'll take a narrow ruling on something. again, I don't know enough about the legal side of this. I'm not a lawyer. I don't want to play one on TV, so it's hard to speculate. Like I said, most people who were Supreme Court watchers didn't think that the Medicaid expansion would have even been reviewed, let alone shot down. So, but at the same time, I can't imagine them doing it either. And what it would really mean, I mean, it would be unbelievable with, again, all these consolidations of these different health systems and all these different things that have been going on that didn't happen, before, that were all started because of some changes to the ACA. Just extremely difficult.
I agree.
Liam, balance between the private market and the government running health insurance. How do we balance the two, given there are arguments for both completely getting rid of the private insurance markets as well as completely getting the government out of healthcare? Well, I think that's why we've ended up exactly the way we are in the United States, because that's what our federalist government, if you will, and constitution-based government puts us all the time. And so is that always the best? No. I don't think we are ready as a country to move towards a Medicare for all personally, because the unknown, I mean, we're all dealing with all kinds of unknowns during COVID and all these things, but people don't like unknown. And the majority of people do have good health insurance coverage through their employer. And those are the majority of the people with power. And we don't know, whenever we talk about presidential candidate policies or whatever, it's all it does is give you an idea of what that person's mindset and what they're for or against. It has nothing to do with what's going to come out of the legislative sausage maker. And so are most people going to be willing to risk their good insurance on something that might come out that they don't know what it is? No, I don't think they will. And most healthcare providers aren't ready to take that chance either in terms of reimbursement. And it isn't clear if everything went, because generally private insurance companies pay better than Medicare, and it varies depending on procedure, but they definitely pay better than Medicaid. So it's not just, okay, what's covered, but what are the reimbursement rates going to be? What are the policies going to be towards rural hospitals, for example? They're struggling mightily right now because most of their reimbursement is Medicare. They have mostly they're highly dependent on Medicare. And there was a story today you might have seen that a lot of them got money through, I'm not sure it was the PPP, but some component of the COVID package from the government that they now have to pay back. So as a loan. Well, things haven't gotten any better for them. It's not like they're generating a bunch of money and these rural hospitals have no money to pay back. And so it's really challenging. So if anything, we're underpaying in some places right now, we're overpaying in some others. Are we really going to say you're an orthopedic surgeon and you're no longer going to make $1.2 million a year and we're going to cut you back to a couple $100,000? No. I mean, I was in discussions in 1993 in Washington as part of this primary care policy fellowship, and there was all this talk then, we're going to emphasize primary care and we're going to cut back on specialists. Well, the specialists had so much clout and power, never happened. Do we know that primary care is a good thing? Absolutely. Should everyone have access to primary and preventive services, which is one of the things we don't have in the United States compared to many other countries? Absolutely. Are we going to take money from the super subspecialists to give it there? No, we're not. So then we're left with a $3.4 trillion healthcare system and very little ability to control costs. So I don't see that changing, but again, I see us continuing to sort of gap fill. But at some point, we're going to have to do something more serious. But just, again, on the insurance side, to me, that's really the easy part. It's that, what do we do with a person with asthma and diabetes and, chronic some COPD or, and have a mental health problem? Because we have 10% of the people in this country that use 69% of all our healthcare resources. So if we really want to hold down costs, in my opinion, we figure out how to provide better quality care for those people and keep their reusing of emergency rooms and going in, readmissions to the hospital down, and manage their situation better. And that's where we're going to really hold down our costs and keep probably quality up.
I had a quick question on the cost part of that. So yeah, is there no, like, can Congress not regulate costs of insurances, or could the government become a player in terms of a producer to undercut private markets? I mean, if we are going to play that game of free market.
I mean, that's the thinking behind the public option. And that was what people wanted back in 2010 when the ACA was first passed, is that they thought that that public option could be the competition with the private insurance companies that they didn't have before. That's part of the thinking. Is that going to be enough? You know, we're in this weird world of in a true, if everything is what's called fee-for-service payment, where whatever you go in to get, you're going to get paid for that. You know, maybe it would, but it's, again, you're squeezing down the reimbursement rates, and for who? Under this accountable care organization system, you have what's called value-based purchasing and movement toward what's called capitated payment, where you're getting so much per person per month, and you have to provide whatever they need under that. So the incentive is to try to hold down. Then, you know, can the government regulate either of those things really well? No, they really can't. Most countries do have, you know, sort of set government reimbursement rates. And in essence, that's what we do with Medicare and Medicaid anyways. We don't negotiate that. We just say this is what we're paying. But because we've got the private insurance companies who are paying a little bit more and kind of around it, it all balances out. And that's like with that uncompensated care issue. But, you know, just rate setting, that's not going to solve it. Could that be a piece of it? Yeah. But I really think ultimately we've got to figure out how to deal with these people with multiple chronic health conditions and try to improve the quality of care for them, which would hold down costs in a more significant way, instead of worrying about whether some poor mom gets on Medicaid who doesn't need it, or some kid, you know, gets on Medicaid or something like that, who, again, in the scheme of things, are cheap. That's not going to hold down costs.
Dr. Damiano, can you talk about how, if there's a Medicare expansion, I know a lot of times Medicare is not included in, dental care is not included in Medicare. So if there's like an opt-in, dental is kind of still left out of the mix. So can you kind of talk about that a little bit more?
Well, this is where, going into that sausage maker of the Congress, that would be for up to Congress to decide. So that essential health benefits list that I showed you that did not include dental, dentistry was not very much involved in the discussions at a professional level in 2010. During the Clinton era, they were right there front and center. There was going to be a strong dental policy. And that's what would have to happen this time if you saw like a Medicare for all, and they were going to decide what essential health benefits are in there. And then everybody is sitting there arguing with each other on what should be covered. And this is when I knew that Clinton was going down. I was in this meeting in Washington with all of what I call the disease of the month clubs. You know, the Lung Association, the Heart Association, the dental groups, and all these different people. And they were all yelling at each other because they all thought it was going to pass. And they all wanted to make sure they got their piece. And then I just walked out, this isn't going anywhere, because if the advocates for it can't agree, then the people that are opposed, it's real easy, you know, to oppose something when you've got all these people fighting. So that's what's going to, you know, come down to. And I think a lot of, you know, the dental association, they are going to be really nervous if all of a sudden you had a single payer type system, because, you know, a lot of people get it through their employer. Maybe there would still be an employer add-on, but it isn't clear whether dentistry would be, you know, or what else, anything would be included for sure in some sort of a comprehensive insurance plan. So a good question on anything in that essential health benefits. Some would argue that we don't need an essential health benefits. What we need is everybody to have a catastrophic policy, and then it's up to them to get something beyond it. And that's really true insurance. But health insurance is not true insurance. It's really there to try to make people healthy, we hope. Right now it's not. Again, it's much more employer-based for recruitment and retention of employees, but that's what it should be. And if we move toward a single payer, I would hope we would be able to move in, you know, a comprehensive one. So I'll take one last question, and that's about the ACOs. So the idea with accountable care organizations, previously, there was federal collusion issues if hospitals or health systems worked with each other and shared information and data. Under the Affordable Care Act, they opened that up, and it was supposed to be a small demonstration for Medicare only that would allow hospitals and health systems to actually work together. And then if they could show that they could meet some quality metrics and reduce costs, they would get a bonus payment. And so that was the idea. Eventually, they would be moving toward, instead of a bonus payment, they would actually be at risk. So if they didn't meet a certain level of savings, they would actually get a reduction. And there's some that are there now, but what we've also seen is that there aren't very many people who can really play in that game very effectively. But it did cause the creation of like Unity Point, and either aligning or buying up with a whole bunch of hospitals and physician clinics all around the state. The university tried to play in this game, and after about 3 years got out and just said, this isn't a good space for us. We've got, you know, a lot of the sickest people in the state. We've just sort of set up in a way that we don't have a lot of control over things, and so we're not even going to play in this accountable care world. And so it isn't clear where it's going from here. I don't think it's a long-term answer to try to hold down costs, because again, I'm not convinced that it's in a fee-for-service world is doing too much. You know, the more you do, the more you get paid for. In a capitated world where you get so much per person per month, the less you do as a health system, the more you get paid. Well, that's not good either. And so they were trying to blend some quality metrics with these things, and it's just really difficult to do on just the payment side. All right, well, thank you. And I hope that was at least somewhat informative or raised some questions. And if it did and you want to follow up with anything, please let me know. But again, I want to thank you all for being a part of the Summer Institute, and we will figure out ways to try to keep some of this going for the rest of the year for those of you who are interested. So thanks.
Thanks, everyone. Thanks, Pete.